Let's go ahead and go to our next panel, Family Caregiving Experiences and Needs, or from a caregiver perspective. Dr. Barbara Sorks, who is Director of Palliative Care Program here at Stanford University School of Medicine, and I will let Dr. Sorks introduce her fellow panelists.
Thank you, everyone, and thank you for inviting me for this important day. I served on the Pediatric Palliative Care IOM committee years ago, and the public day then was held on an auspicious day. It was September 10th, 2001 in Washington, and the day was extremely impactful on us as a committee in terms of really giving us that true experience of the issues and the policies that we were looking at. So I hope that today has the same impact through our panels and through our talks. I will have my panelists, I want them to be able to see the presentation, so toward the end of my presentation, I'll invite them up. Lynn talked about definitions, and this continues in another way. Caring for someone through illness is an epic task. Seeing a family member through a health crisis is an experience that nearly everyone must face. Yet caregiving, as a rite of passage, is only just beginning to enter our cultural and literary and healthcare system consciousness. And I added that in because this is actually a book of literary essays, but very much addressing these issues. Some language issues, which Lynn also alluded to, and we didn't compare notes ahead of time. Interestingly, in the British literature, the word usually used is carer, not caregiver or caretaker, but carer. And to me, that has a very encompassing emotional connotation to it. It doesn't have tasks written into the actual name. It's just family carers. What we seem to use here most is caregiver, which has a very active, task-oriented connotation. And much of the literature, including the next quote, which I'll show you, talks about informal caregivers, relatives, friends, partners who have significant relationship with and provide assistance to a patient with a life-threatening illness. So language, as we all know, in palliative care is important, and I think even how caregivers are named has some importance. This is a very recent article on care of the caregiver, and Applebaum and Breitbart say, comprehensive palliative care involves attending to the needs of the caregivers as well as to the needs of the patients themselves. Special attention should be paid to the unique burden of informal caregivers, not only for the benefit of the caregiver, but also for that of the patient. And so we are extremely appreciative today of having a panel devoted specifically to the family caregiver perspective. A child who encapsulated the wisdom of the entire panel said, "My family and I are in this together. We haven't been sleeping well lately." In any situation, but certainly in the situation of serious illness, it truly is impossible to separate out patient family members. The family is a unit. And it's a unit unto itself with its own distinctive identity, strengths, and vulnerabilities. And importantly, and you'll hear this through the panel, developmental level, not just of the individuals in the family, but of the family unit. Under optimal circumstances, the interior of the family assumes a central role in preserving the patient's psychological integrity. Very, very important that really is the bottom line of that surrounding care or caregiving. Resilience is a concept that I think has gained more and more prominence in almost every field of human study and human endeavor. A very basic definition, but a very important definition for the task here of resilience is the ability to bounce back after trauma, to transcend dire circumstances and adversity without permanent rupture. And so it's not talking about some dichotomy, which many people think it is, of being strong or weak or strong or vulnerable. It talks much more about the adaptation and being able to go through and negotiate adversity and yet be able to come back. And a resilience approach, and again, there'll be great evidence of this in what you'll hear on the panel today, focuses on people's strengths over deficits. And it's a very different lens from the old, much more pathological focus. The general risk and protective factors for individuals and for families as a whole, the internal resources of each individual, of course, just their own strengths and vulnerability, the family climate, and very importantly, and both panels address this today, environmental supports, the presence or absence of extended family, friends, the medical center, the community at large. In thinking about resilience, we have to think about the tasks that face patients and families in facing life-threatening illness across the lifespan. They're really these universals, and in my thinking over many years of this work, I've really come to think that there are three axes, and they intersect. They look different by age, they look different by family, but what are the threats? The threats to both individuals and family caregivers are the feared loss of control over a situation, over an illness, loss of identity, who will I be? Who am I now? Who will I be? And loss of relationships, which is, of course, the base and the very emotional bottom line of life-threatening illness. A very important piece of neon art that I came across once, and I think it really says something. It's so many people, as we all know, even when you say you're talking about palliative care, they say, isn't that helpless, isn't that hopeless? It's not helpless, it's not hopeless, but what is the antidote? Where do people find their resilience in situations that very often look dire, helpless, and hopeless? The facets of resilience, and again, these are characteristics that you'll hear from our panelists, are having some sense of control in a situation, which often feels absolutely uncontrollable. Challenge, by definition, illness in the family is a challenge. The extraordinary commitment that we see in family caregivers for their loved ones, and the importance of communication, both within the family and between the family and the medical team and the medical system as a whole. And these characteristics really pervade through time, through the whole experience. The facets of the caregiver experience, and these overlap very much with what Lynn presented. The first and bottom line one, very much as the loss of relationships was the bottom line loss, the profound emotional impact of life-threatening illness in the family. The literature focuses very often on the patient and then adds on what the impact is on the family. And most of the family literature comes in the bereavement phase. That's where there's more focus on families. But it is so critical to really understand what the family is going through during the illness. It's a profound emotional impact, often with trauma built in. I'm going to show you two children's drawings that I think attest to the imprint of the experience. In both cases, these were children who had an ill family member, and I'd ask them what was their biggest worry. In the first case, about her sister who was ill. In the second, about a child's father who was ill. So the child, what's your biggest worry? Dreaming of my sister in pain. And there's a little kid in the bed and a big person saying, ow. So we focus so often on pain and symptom management because the patient is physically feeling it. We sometimes forget that for the family who is witnessing this, living with it, trying to ameliorate it, there is a traumatic component to that as well. And the other is the child whose father was ill, and when I said, what do you worry about most? This was his answer: death and loss. So when I talk about facets of the family caregiver experience, these two, to me, are the constants. They're not there every day. They ebb and flow over time, because often trajectories are not days, weeks, and months, but years, but they're ever present in the experience of the family. Other facets: the history of loss and stress in the family. What are the strengths and vulnerabilities that predate the illness? The impact of culture in its broadest sense, and Vijay will be talking more about that in her talk. The acquisition of complex medical information and the establishment of relationships with healthcare professionals. In fact, I could have called that just negotiating just a huge, overwhelming system that most people have no knowledge of before they're thrust into it. Changes in family structure, roles, and relationships with new and added responsibilities. Communication patterns within the family and between the family and medical team. Sometimes people say that's about the most challenging. Exhaustion. Simple exhaustion, and financial strain. And those last two can undercut absolutely the strengths and everything else, but the exhaustion and financial strain can take a huge chunk out of people's coping. There are some issues that I think are particular focus when a child or adolescent is the patient, and I do have two parents today on the panel to speak. When a child or adolescent has a life-threatening illness, I think the very first thing is that it shatters our assumed sequence of mortality. It just seems like this can't be, this is upside down. It should not be the older generation taking care of a child. In pediatrics, there are many rare diseases, and because of that, specialization is at key centers. So for many pediatric families, they must go distant for specialized care. So there's a fair amount of dislocation in the pediatric palliative care field of families who come uproot for weeks and months before being able to return to their home base. This is a very important one. Many parents are young without past experience with illness or death. So when you think of many young parents, often in their early 20s, they haven't lost anyone yet in their life. And so they have absolutely no rehearsal whatsoever for loss in general, much less threatened loss of a child. Jim, one of my panelists, added this point, which goes along with it, and is very important. The couple relationship also is often relatively new. And so the focus now shifts almost exclusively to the parenting role. So the couple hasn't been well established before their own definition, self-definition, has to change with an ill child, often for many years. Parents are often the decision makers for their child. It's an overwhelming responsibility. You will certainly hear evidence of that. It's an over responsibility when we make decisions for and with our partners, but for a child has a specific added acuity. And sometimes siblings can be vulnerable, anxious that the same thing can happen to them. Not all siblings, for sure, but there is a sense of, it happened to him, it could happen to me. So there can be a lot of added anxiety. So I'm really delighted to introduce the panel to you today, and it's been an interesting experience of working with two people whom I've known for a long time and two people whom I've had several very intense telephone conversations with and feel well acquainted now. Our panelists are Joanne Bard, and Carla Reeves. Joanne and Carla I have only met by phone in the last few weeks, and Carla and Joanne will be speaking to you about their current ongoing experience of caring for their partner. Jim Santucci and Alison Yisrael. Jim and Allie will be reflecting back on their experience of caring for their child. For those of you who have the packet, there's some references after. The one thing, since I have one more minute, I want to add is that Jim and Allie are part of the Family Partners Program, which is directed by my partner in crime and colleague, Nancy Contro. Nancy? And the Family Partners Program, which you may hear more about over the day, a group of parents, bereaved parents, who advise, teach, help enormously with our overall palliative care program. And one of their missions is to teach and educate, and being on panels like this is how they feel that their word really carries to clinical knowledge, research, and policy. So thank you, all four of you. All right, so the format of this panel is that I have three very detailed questions, and I'm going to ask each one, and then each of our panelists will answer, and then go on to the next and next. if we're good about timing, there actually should be time for questions afterwards. So I'd say probably hold your questions so that you get the whole experience, and then you will be able to talk with the panelists after. Okay? So first, I'm going to ask the panelists to please introduce yourself, your partner and your child, your family constellation, and briefly describe the medical status and condition of your partner or child. What was the illness trajectory like? What were the settings of care, if relevant? And then a very important focus on you. How and when did you recognize yourself, or were you informed by the medical team that your partner or your child was entering an end-of-life phase of the illness? What was your reaction, and how has your life changed as a result?
I'm Carla Reeves. I'm a nurse midwife by profession. I'm retired U.S. Air Force Nurse Corps, and I still work full-time for Palo Alto Medical Foundation in Fremont. Dusty, my partner, and I have been together for, I'm guessing, 40 years now. Dusty has had a multitude of health problems. She has rheumatoid arthritis and peripheral vascular disease, but about 6 years ago, she was diagnosed a month after quitting smoking with end-stage chronic obstructive pulmonary disease. We were informed by this by telephone. The diagnosis was made via X-ray and blood gases. And then we met our primary care doctor, who then referred us to pulmonary, who were then going to manage Dusty's symptoms. Now, my initial response was I was peeved because this was a smoking-related issue, and I was really torqued because this was going to impact everything I do. And Dusty became oxygen dependent. They managed her symptoms with inhalers and certain medications. She still had to be managed for her arthritis. But it also involved for us a huge change in responsibilities. Dusty managed the house, I managed work. Dusty took care of our dogs. We have 4 dogs, 3 Siberian Huskies and a Husky wannabe. These are not small dogs. So we have a lot on our plate. And when we travel, we would take all 4 dogs. But now we had to adapt our vehicle to accommodate oxygen, extra tanks, because you can't go anyplace without oxygen. We had a mobility cart because Dusty's distance was markedly impaired because she lost a lot of her mobility because she didn't have enough oxygen to walk for great distances. So it made going any place a huge event. Lots of pre-planning, which I wasn't really that thrilled about. And then when we went on vacation, our vacation spots were Disneyland. Okay. So that required that you call ahead to make sure oxygen was available, that the concentrator was at the hotel, and after driving all day to get to the hotel, find out the oxygen's not there, the concentrator's not there, and everybody's up in arms. So I spent a lot of time putting out fires, making phone calls, getting angry on the phone, which is never good for anybody. But these were issues that we'd never had to deal with before, and this was not my plan for retirement. So the upshot was that she continued to be oxygen dependent, but eventually adapted. We did really well. She started exercising, improving, and doing better. And when they told me end stage, I kept thinking, well, this is not end stage because she doesn't look end stage. She doesn't act end stage. She certainly didn't have the posture, the breathing. And of course, my immediate response, this is not my area of expertise. So I was Googling, I was researching, I went to all the pulmonary conferences to find out all I could about this disease process. And mind you, we go to the Veterans Administration Hospital, and they were very, very good at giving us information. But still, it was hugely a problem for me. And Dusty would always ask me, like I knew anything. My area is women's health. I don't know anything about the lungs. My my concentration is elsewhere. So she would always ask me this stuff, and I said, don't ask your doctor, because I don't know. But the thing that's remarkable about our situation is that Dusty had thought about this for a long time, and actually I have her medical power of attorney, and have always had that. And it has never been an issue for me or Dusty that I was always at all the appointments, and a lot of the questions were directed to me, or I was answering, and I was doing a lot of managing. Dusty managed to a point, but I was managing a lot more, which I don't like all that extra added responsibility. So that has been huge. It adds stress for home, where I'm supposed to be stress-free when I come home from work. And I have a very, very busy practice where I am, with lots of changes in our department. So it was huge. And luckily, I have friends who help me.
The yellow light means 1 more minute.
Okay, see, like we know anything. But I have adapted. I'm not a very flexible person. I have learned to be a little bit more flexible. And we have had to do a lot of changes as far as finances and pre-planning. So it's also forced me to do some pre-planning too, to make sure we have guardians and the like in place. But, you know, this isn't what I've signed up for. I am familiar with long-term illnesses. My parents have died, and my aunt and uncle, but I didn't expect this. You know, we've been together for 40 years. It's a huge, huge change. Luckily, doing well now, but we'll get to that part. But we were only referred to palliative care 2 years ago.
Thank you, Carla. Sue?
So my name's Jim Santucci, and I was the caregiver and father of my daughter Jillian, who passed away in 2008. She was 11-year-old when she died. Our story was she was born in I have a list here because there's a lot, so I want to keep to my time, but to give you a background to show the length of caregiving, she was born in '97 in Hawaii with Down syndrome, and diagnosed with mild dysplasia at 1 year of age. At a year and a half, she was diagnosed with acute myeloid leukemia, and was treated aggressively with chemotherapy protocol at that time. At the end of that year, we thought we were out of the woods. 3 months later, in the year early of 2000, she was rushed to the ER with congestive heart failure, secondary to the anthracycline from the chemotherapy. And I think, and thinking about the lifespan, she was 3 years old, 2 years old at that point, so she was put on multiple levels of IV medications for her to maintain her. I think we were in the hospital for 3 months at that, 3 weeks at that point to maintain her life. And it was at that point, up to that point, thought, well, our child has Down syndrome, leukemia, we beat the leukemia, we're good. I never really thought about caregiving per se. The decision for me, I realized this is a long-term care, is when we came out of the hospital, fortunately, and thankfully, that first time in the ER after basically the heart dysfunction, I realized I have a 3-year-old child with congestive heart failure. I know about congestive heart failure from some older people. That's sort of where you go. And they end up dying, and I see the life, and I go, you know what? My child is going to die. And it's going to be sooner than a lot later. So I think that was the decision point for me to understand, like, ooh, this is about figuring out what I need to do so that she will continue to thrive and get the best quality of life. And I think one of the questions here is, you know, how and when did you recognize? Well, that's when I recognized. I go, I think physically I recognized it. Emotionally, I didn't want to at that point. And my wife and I went through a lot of decision making, and I'll talk a lot about that later. But the big point was recognizing at that point in time, you know what, we are now caregivers of a very sick child more than parents. We are parents first and foremost, but everything switched on that day. I remember driving home from the hospital just thinking, like, I didn't sign up for this, but gosh darn it, she's going to get the best quality of life that she can possibly get, no matter what distance of this life is going to be. I remember committing myself to that, and my wife and I even talking about that. We're going to do everything we can. We're going to take a holistic approach. We're going to give her the best care. We were moderately income. I worked for a nonprofit agency. Didn't have a lot of money, but we're going to do everything we could to make sure that she got the best care that she could. And I realized that sort of started my path on this sort of palliative care, sort of hospice care, sort of end-of-life care, all in my mind thinking, I never want this to happen to me or anyone else. So how did my life specifically change at that point was, well, our normal then became crisis. That became our normal. I remember when we moved here, what happened a year later, we moved here from Hawaii to California because keeping her heart function on medications, it wasn't going well. So we thought we need to find another place to go. We moved here, got treatment at Stanford. They added another different litany of medications to support her. And she did fabulous on those, and she had good spots of her life. But our life was nothing normal compared to typical, right? It was crisis management. I have a good friend from my church who would always tell me, Jim, you're in crisis mode 24/7. That's why this is so hard. And my normal became crisis mode. My normal became, let's keep her out of the hospital, let's keep her out of the ER. Gosh, the last place you want to go is to the hospital. That's where she's going to get sick, right? So that's what you're thinking in your mind, even though the child is dying. The last place she's going to get sick, that's sort of this weird dynamic you go through as you're caring for someone who's sick. Ideas such as her Down syndrome was no longer an issue. That was like, well, that was like the last thing I'm thinking about. I'm trying to keep her alive. So I think that changed. So the wrestling match that happens internally, though, as you transition from, I am now the caregiver to kid this child the best life they can have, it's no longer typical anymore. So there's the physical aspect of it. It was easy to turn that switch, but the emotional aspect as a caregiver was incredibly difficult for me. I'm from a Leave It to Beaver family, 5 kids. We went to the beach every summer, Cape Cod, the whole thing. I couldn't do that with my child. The best outing for me was driving to Half Moon Bay from here, 15 minutes, walking to the beach, putting her toes in the water and going home. And that was a wonderful day for her. Realizing that was what's important to her was part of my emotional transition as a caregiver as well. So that's a little bit of my background and my daughter Jillian. Thank you.
Joanne.
I'm Joanne Barr. We have such a different story because we're in the later elements of life. I'm 81 and Murray Ross is 88. And I was born in Ohio, lived in upstate New York and Florida before I moved to California in 1966. But my husband of almost 50 years died at home in 2001 at age 77, having had 2 bypass surgeries, colon cancer surgeries, had developed adult diabetes. And then later that year, my mother died, having lived with us for 5 years, since she'd been going downhill for some time. And I'm an only child, so there was no one to take care of her but me. And I loved having her with us for that period of time. So I'm well equipped to handle my new situation if you're ever able to handle a situation such as this. But I don't think of it as caregiving. I think of it as doing what you need to do for someone that you care for. And I guess I'm a carer. But Murray and I met through Kiwanis, and after 2 years, he finally asked me to dinner, and several months later, he moved in with me. That was 8 years ago. So we've had a really good year. On one occasion, he said that he needed knee surgery, and I volunteered to be there for him for that, and he just simply couldn't believe it. So through pneumonia, 2 knee surgeries, bowel obstruction surgery, and we're still hanging in there. He sometimes moans that he can't do what he used to be able to do, but which of us can? Huh? So, and he feels badly for the care that I need to, as I attend to his, outside needs. He's able to take care of himself. He bathes and, he can even do the dishes on occasion now, so that sort of thing. But I remind him that he would do the same for me, and then that ends that conversation quickly. Murray has severe arthritis, and so he's always had a lot of pain with that, but now he has a very high white blood count that is going up way too fast and too high. It became only alarming a month ago, or that's when it got our attention. I don't know which is which. But as we understand it, it's leukemia or nearly so. And he had prostate surgery a number of years ago before I knew him. So the cancer cells, as you all know much better than I, stay around. So there's no treatment for him at this time. But, several years ago, he was talking about how long he wanted to live. And he says, well, he's going to live another 5 years. So I made him sign this little note, and it's up on the refrigerator, that he's going to live another 5 years. Well, there's a year and a half to go on that 5 years. And I doubt that we're going to make it, but we're going to do the best that we can. Thank you.
Thank you, Joanne.
And thanks for letting me be here for this.
Ally?
I'm Allie Israel. Tell you a little bit about my family. My husband and I have 3 daughters. Our oldest daughter, Isaiah, is 10 and a half. Our youngest, Avi, is 6. And our other daughter, Micah, died in 2006. My caregiving experience with her was quite short, although when I hear about caregiving experiences, I realize that we experienced everything just in the most condensed fashion that you could. After a brief history of seizures, Micah went into uncontrollable seizures and was here at Lewis-Packard Children's Hospital in the pediatric ICU. They put her into a propofol coma, into a medically induced coma, we were told, in order to calm her brain. And then we would wait a couple of days, and after a couple of days, they would lift the medication and we'd see what would happen. And although this obviously seems like it is an extremely serious situation, but like a very bleak situation, everyone around us, all of the doctors in the PICU, the fellows, the residents, were very positive that the outcome was going to be okay. And so we had 3 days of being very hopeful, with everyone around us being hopeful. And on the 4th day, things changed drastically. When I walked into the room in the morning, the nurse told me that overnight Micah had developed diabetes insipidus. She didn't mention at the time that that is a sign of brain damage. She only mentioned that it was, not being able to manage urine output is how we understood it at the time. So I was like, okay, something new, but everything's still going along as planned. And then what I noticed as the day wore on is that I kind of noticed it in the morning, but it became more apparent as the day went on, is that our room had significantly less traffic in it. There was a lot of, previous to that, even though it was two of the other 3 days were on the weekend, there was a lot of traffic in our hospital room. People checking things, EEGs running, things going all the time. And there was significantly less traffic. The other thing that happened is that Micah was supposed to be receiving an MRI that day, and it was changed to a CAT scan. And all I knew about that was that I had been told she's having an MRI because a CAT scan won't give us enough information. It's too global, it's not specific enough. So that change was made, but I didn't understand why. And then later that day at around 5 p.m., I was told that we were going to have we're going to have a caregiving meeting team at 7 o'clock. At that meeting, where there were a lot of doctors, and my husband and my parents were with us as well, we were told essentially that it was confirmed through the CAT scan that Micah was brain dead. So she had diffuse brain swelling as a result of the seizures over the last several days. The interesting thing about that meeting is that it took a while for me to understand, even though they were explaining to me, and I reflect back, it would be interesting to have like the objective experience there, because I feel like I wasn't understanding what they were saying, whether there was hope or not hope, because there was so much hope and there was such a quick transition to no hope. And I don't know if it was because of the way that they were speaking or what I could understand. But what I do know is that I had a sense that whole day that something was wrong. The lack of traffic, the switch of the MRI to a CAT scan, and I really felt that day I felt profound loneliness that day. I felt, it sounds dramatic, but I felt abandoned, like I was by myself. Even though I was surrounded by, people in a hospital, I felt very shaky. I felt on my own. I knew something was wrong, but I didn't know. And it's interesting that I think is how I found out really that something was wrong with Micah versus that meeting. That meeting confirmed it for me, but I kind of knew throughout the day that is where we were heading. In fact, when I was told at 5 o'clock that we were going to have that meeting, I was with my daughter. I see I'm running out of time. I was with my older daughter at the time, and we were having ice cream, and the phone rang, and before I picked up the phone, I said, this is the last ice cream I'm going to enjoy. And so that's how I kind of had sensed it that way, so.
The second questions. Please talk about a pivotal decision time for you around defining goals of care for your partner or your child. What was the nature of the communication with the medical team? Were you advised? Were you heard? And do you have recommendations for the committee on how best to communicate with the family caregiver around issues of decision-making?
I think our defining moment was about 2 years ago when Dusty, after we had purchased a weekend home, started developing a horrible, horrible cough to the point that she was passing out. At that point, a pulmonologist and our primary care doctor met us, and we were then moved to palliative care, which to me was like, oh, 1 foot in the grave and 1 foot on a slippery banana peel. I'm sure that Dusty didn't view it quite that way, but, I could see the writing on the wall. And when we got to palliative care, here was somebody who was really interested in controlling symptoms and making Dusty's life easier, which in turn made my life way easier. The huge decision problem was, I think it's been over a year now, but on New Year's morning, I woke up to find Dusty unresponsive. The night before she was fine, but she was unresponsive in the morning. We had a DNR in place, but kind of oxymoron. We also had Life Alert. So after much hesitation, knowing that I was going to be in deep doo-doo if I did this, I went ahead and activated Life Alert. When the emergency team arrived, I kept telling them, she's a DNR, you cannot intubate her, but please give her some fluids. So she was taken to our local emergency hospital, and I followed behind after my neighbors found our DNR paperwork. Thank goodness they can see, I can't at that hour of the morning. We went to the emergency room. I followed in. There was never any question of who I was because apparently they thought I was Dusty's daughter. So it all worked out good, and I'm running around. The doctor is taking care of her, and he says, we need to drop a central line. And of course, being the hysterical person I am, I call one of my friends who happened to be on call in the hospital. I said, this is the thing. She says, let him put in a central line. Go ahead and do a fluid resuscitation. She was in CCU for about 2.5 days until the government reopened, because it was a holiday. And then we transferred Dusty to VA, to palliative care. And the palliative care doctor there says, oh, good, she can go home the following Monday. And I'm looking, she's can't even take care of herself, she can't breathe, she can't do anything. I said, well, this isn't working for me. So I said, she was fully functional before this event. So then it was decided amongst all of us, her social worker, the doctors, everybody, that we would move her to a rehab floor where she rehabbed and then actually came home a month later fully functioning. Her only big deficit is she can't hear worth a hoot. But for us, that was huge. We did clarify the DNR because I'm still paying for that. But her life is much better, and her symptoms are much better managed now. So it's hugely different.
Thank you, Carla. Jim.
So I think the pivotal decision, I have to say, I had my list of the lifespan. I've used these for different talks, but when I was in the service, I served as a battalion infantry officer operations guy, and we'd have matrices called decision planning matrices, and you put it, and that's a critical decision point. You make that one, you got to go this way. You make that one, you go that way. So I look at my sheet here, and there's a lot of D's on here. D with a circle means that's a decision, a major decision you got to make. So I'll talk in general about them, and then briefly about one specific. That the first decision was when we were in the ER. We said, what is going on here? She's on all these medications. Is she going to die? If she's going to die, we want to take her home. So we called a meeting with the staff. We said, what's happening? And I still remember this conversation with this one wonderful ER doc from Tennessee. She goes, Jim, I wish I could tell you. Wish I could tell you what's going to happen. But I know if we can get her to the next day, then maybe we can get her out of here. So it kind of changed my frame. So that was the big, do we take her home? The next one was, was a heart. Do we do a heart transplant? I don't know. Should we? Down syndrome, chemotherapy? I don't know. That was another one we had to try to navigate. Move to California. Well, we ended up moving here. That was a huge decision. Picked up the whole family, moved. Fortunately, it was just my wife and I and her. Got it here, and the doctor started talking about heart transplant again. So again, decision, do we do that or not do it? If we do it, then what's going to happen? But the biggest is in the last minute here is towards the end of her life, in February of 2008, we went for a regular clinic visit, and her blood work was just off the charts. Everything was wrong with it. She was otherwise fine, but something had happened. Maybe the heart had said, okay, I'm almost done here. We were in the hospital for 3 weeks, and at the time, we talked about putting her on an IV drip medication called milrinone, which would give her that additional support. She was retaining a lot of fluid. She was just, and so we talked with our medical team at the time, and we sort of wrestled with that decision. We knew once, at least I understood it to be, once we made that decision, one, she'd be tethered to an IV, and in my mind, at least I understood it, that it's going to help the heart, but it's going to quicken the pace of deterioration of that heart, and she's probably going to die sooner than later once we do that. Our physicians had the wherewithal to know her as much as we knew her, and I asked him straight blank, I go, what should we do here? Is it time to do this med? And he goes, I know her, and she's bounced back a lot. Let's give her some time. That was probably one of the biggest decisions we made. There was validation, there was affirmation that, Jim, you're doing the right thing, whichever decision you make. So that's one of the points with these decision-making points is we want, as caregivers, want affirmation, and ultimately the final decision should be our own. But that was huge. So we decided to wait. So she had about 4 months in the summer where she got a good quality of life, and then it was in August that we went in that milrinone. And about a month from putting her on that milrinone, she passed away.
We're at such a different level in our life that it's really heartbreaking to hear the other stories from me. But when we were in palliative care a week ago, they had suggested that we contact hospice. And my first reaction was, I don't need hospice. I don't see any reason for hospice. We're able to, I'm able to take care of myself and able to take care of Murray and do whatever needs to be done. But we finally made the decision that it was a good thing. So Murray is scheduled to go to Portland to visit his beloved daughter, Laura, on the 6th of June. And it's a trip that he had planned for a long time. Now, Laura is going to fly down to go up with him. And then the day before he comes home, I'm going to fly up and come back with him. But we're not going to let him fly alone anymore. He, coming back from Hawaii a couple weeks ago, he had difficulty in the plane, and they put him on oxygen for the last half of the trip. So we know that flying by himself is not something we're going to let him do. But when he comes home from Portland, and we're scheduled to have hospice come in, and so we can get to know them and they can get to know us, and they'll be able to apparently be a great help to us as time goes by. We live every day, and we make plans for small visits. We don't skirt the issue that time is limited, but we don't dwell on it either. Our families are all aware of the situation. We're all able to talk about it, and they're helpful in conversations. It's probably a little harder for his daughter Laura that he's been closest to. She says she's really having a hard time with it. So it's going to be wonderful that they've got a number of days together in Portland, as well as he's got 4 great-grandchildren up there, too, that he's looking forward to seeing. We did, when we were in Hawaii, we visited his daughter Pam, who, among other things, she's works at the Queen's Hospital in Honolulu. So we had a nice visit with Pam. And he has a son that lives in Sunnyvale. We each have 3 children. Our firstborns are both Pam's, which is kind of interesting. And we each have a son that lives close by, and everybody else is kind of all over the place. But we're very supportive of each other. We do lots of things together, and we hope we still have a lot more time.
Joanne, could you just comment? Joanne?
Yes.
Going to all the appointments together.
Oh, I was going to bring that up later, but
Okay,
I'll do it
okay,
now
good.
if you want.
You can do
Okay.
that. Okay. Ally?
So I'll say something really brief about communication and then decision-making. As far as communication is concerned, I feel like it's important, and I like how Jim said that his team really knew him well. It's so important when the team knows the family and vice versa, because I feel like I was someone who wanted a lot of information, wanted it as soon as I could get it, wanted to know everything, wanted to ask questions, and I think partly because of the brevity of our situation and partly because of the rapid change that I couldn't get all that information. And I couldn't also necessarily ask more and more because I think partly I felt the being in an ICU, the in and outness of everyone, so doctors in and out. Also, the next thing I sensed that they didn't have a lot of time necessarily in one sense, but also I can't stress enough the profound vulnerability that one feels in a situation like that, whether your child has a life-threatening illness. And then after that, I mean, every medical situation I'm in, there's, someone who is articulate and educated and knows how to navigate the system, just the change that you have and the profound vulnerability and the difficulty in asking for what you need is huge. As far as decision-making, I think I have two things to talk about. One would be, and probably most obvious, so we were told in the evening that Micah was brain dead. We were told she would have another clinical exam in the morning, and then it would be our decision of when to take her off of life support. I dreaded and still dread that decision that I had to make of when to do that. It was very clear that it needed to be done. She was very unstable. It wasn't like, oh, we can just do this for a week or whatever. I mean, it was something that needed to be done. But what made it even more difficult was the fact that I had my daughter at home, and I was really torn between, I'm going to talk about in the next question that Barbara has, bringing her or not, but what I was really torn about that day is I had to let go of Micah, but take care of Isaiah that day also. And so how is I going to balance that? And I thought about it even to the extent of I have to get home and tell Isaiah about this before bedtime, before it's too close to bedtime, because I don't want her going right to sleep after this. It was balancing really impossible needs of what I needed with my time with Micah and being able to care for my other daughter as well was really something that's still difficult to this day, making that decision.
Okay. What sustains you? What sustains you during your partner's illness? And Jim and Ally, what sustained you during your child's illness? What is or was helpful for you? What could be done better? What would you recommend for other family caregivers? There's a concern that palliative care means the focus is on quality of life at the cost of longevity. What role does palliative care, either actual palliative care referral or palliative care principles, what role did that play for you, or does it?
Well, what sustains me is I actually work, so I go to work, and it's a different set of stressors, and I have lots of friends, and luckily they're like to listen. I don't think they have a choice, but they listen. Um, And, you know, they ask me when I'm going to retire, and I'm guessing never. So it's all good. I think the important thing is that as a caregiver, I know that we tend to talk and run over and all that, but I think it's really important that we listen to family members. We're the ones who are living with our loved ones. We're the ones who are noticing the subtle changes. And I think that when Dusty had this acute onset 2 years ago, nobody was listening to me. And I think that as a result, we ended up with this huge event. But, you know, in the long run, it was a good thing. I think for caregivers, it needs to be recognized the added stress that we have. And the nice thing about the VA is they actually had a program where they had a caregiver support group. For me, it was difficult to actually physically go to a support group, and they had a telephone support group. It was a pilot project. It only lasted, I think, 12 weeks, 6 to 12 weeks, and then it was over. But it's not over for us. We still need that support. And I think we should have some kind, even if it's just a telephone support group, that every Wednesday or whatever day it is, that you can just call up and say, I'm having not a good day. I think that having that available is really, really important. Now, as far as if palliative care is, for me, palliative care has been a godsend. Mainly because Dusty's symptoms have improved so dramatically. Her symptom control is better. You know, before when I've gone on vacation, I went on a continuing education cruise. I had to take a satellite phone with me and be prepared to get off the ship and fly home immediately. It's not very restful. But because her symptoms are controlled, this last vacation that I went to Phoenix, everything was fine. I had a good vacation. First time in years that I didn't get phone calls telling me all the bad stuff that was happening. That was huge. And I see palliative care as actually helping to coordinate all the care and to make sure that her symptoms are controlled so that my life is better. Jim?
Sure. I got my computer here because I wrote something in an application for schooling after Jillian passed, and instead of trying to remember what I wrote, I just brought it, so that's why I've got that. But that would be part of the second question. You know, what sustained me then? I think my relationship with my spouse, certainly, we had each other. We kind of committed to, we need to get through this together. We were both committed to our daughter equally. We both have different personalities and uniqueness, how we approach life, but that's one thing we were united on, is just we're going to give the best darn life we can to our little girl. The other part was just the familial support. I'm from the East Coast. My wife's we both are not from California, so we didn't have familial support here. But you know, during the last month of my daughter's life, my family back home had a big family party and did a little party for her to raise money. Somehow it helped. That, just knowing that they were doing that added a huge sense of somebody's got my back. Even though I knew it really not going to make a difference, that we're down this trajectory, there's an end in a minute that we're going to hit. Them doing that was huge. And then the other part of is having a really good healthcare team that knew us and we knew them. We had some confrontations with people. We fired a few doctors and nurses along the way. But in general, we really decided we're going to work with these folks, and if they're willing to give to us and let us be part of the team as the caregivers, as ones making decisions, just because they have the MD at the end of the name, they don't know their daughter more than I know my daughter, that kind of thing. And we really got a good team. Her phlebotomist came to her memorial service because they knew her. We knew which one gave the best blood draw, and we always went on that day. And they were endeared, and we were endeared to them. So it was a tit for tat kind of situation where we're going to help each other because we're all knowing where this is going. And in terms of what I would want people to sort of remember is I wrote this for some schooling that I decided to pursue, and I'm sort of waiting. So my daughter Jillian lived just a short 11 years, and the lessons I learned during that time were powerful and transformative. One thing that is clear from my experience is that healthcare professionals are only just beginning to understand how to meet the needs of families facing the impending death of a child and delivering quality and appropriate end-of-life care. I've read numerous articles, watched documentaries over the past few years about the shortcomings in our healthcare system while caring for adult patients when modern medicine can no longer save their lives. The problem is exacerbated when the patient's a child. The end-of-life or death experience cuts deep into a family fabric and really contradicts our understanding of the normal order of life. I describe it as this. You know, you're traveling in a car on a high speed and a terrible storm on a winding mountainous road, knowing full well that at some point you will crash through the guardrail into the abyss below. Unfortunately, you do not know when the journey will end, but you know how it will. Some turns are easier than others. Sometimes the storm subsides, and there are even times of happiness and laughter. You're in constant battle with your emotions. You do your best to prepare. Though the final destination may not change, the healthcare team has the important role of making this road as smooth as possible. It will take a determined effort and focus to understand the intricacies of meeting the needs of these families and their children. Paramount in these efforts are three things in my mind. You've basically got to have a great transition of care from acute care to hospice or palliative care, which we had. And then the second one is a great communication with the healthcare team, and also promoting a very holistic approach to care that's right for the family. We did everything we could. We went to acupuncturists, we went to chiropractors, and our cardiac surgeon, doctor was fine with that. He was approving of that. We took the very holistic approach because at the end of the day, when someone's dying, if you don't take that approach, we're doing them a disservice, whatever might be right for them. So those are the things I would leave with, how we can make this system better. So thank you.
I see I'm going to have to start taking better care of Murray. What do I do for myself? Well, I do like to play bridge. I've been playing bridge with the same group for about 20 or 25 years. I try to go to the 24-hour fitness 2 or 3 times a week. I'm active in Republican groups. Yes, there are Republicans around. I happen to be a very moderate Republican. And through our Kiwanis Club, where we've been together for so long, it is we're like a family. We like to eat out. We like to go to the movies, and we try to go to the movies at least once a week. And we're never at a loss of what to do. But I'm so grateful that I am in excellent health. And I've got a lot of energy, and I'm 81, so I figure I'm pretty lucky. I hope that we can enjoy a lot more time together, but with what time we have, we're trying to make it quality time with no regrets. But the care and attention of the doctors at the VA hospital in Palo Alto, especially palliative care and hematology, have just been invaluable. I hadn't even heard of palliative care before, but I always went with Murray, almost always went with Murray to his appointments before, but now I take him to all of his appointments because I want to be informed and know everything that's going on, and to see what I can do to help and what I can understand, because, 2 people listening to things, we take them in differently, and so I think I'm able to help him a little bit in that way. But I am such a fan of palliative care that I could stand on a soapbox and proclaim the benefits of the program. And our quality of life has been so much better because of the management of the palliative care doctors. They not only help you with the overall and help you with the pain medications, but the fact that you're able to talk with them and they listen to you. Mm-hmm. And I'm very, very grateful. So if he's in less pain, then I'm a happier person. And that's the way we want it to continue to be if we can.
What I realized in reflecting on this question and our experience in the PICU is that we had a lot of support, but I realized that there are different types of support. So when we found out that Micah was not going to wake up, I called friends, and we were surrounded by people. And the next morning, our rabbi came, and we were absolutely surrounded by people. There was a lot of love and support for us. But what was missing in that, and it took me a while to realize I had these feelings like I didn't, or these experiences and reflecting back that I didn't get what I need. And what I mean by that in certain areas is, I'll bring up two examples. One is someone mentioned taking a picture, and I immediately said, no, this is not something I would want to remember. That sounds morbid or not something that's okay to do. Now, being a part of the Family Partners Program, we have bereavement kits that are given to families at the time of death. And in the bereavement kit is a disposable camera. And obviously, at this point, most people have cameras on their phones, but it's more of an opportunity, a talking point. And there's a letter attached to it that talks about why you might want to take a picture. And you don't have to look at it now, or you don't have to look at it ever, but that this is a part of your child's life, and it's a part of your experience with your child, and it's something you might want. And so that kind of guidance, that kind of expertise, I had love and friendship and support surrounding me, but those people didn't have experience in losing a child, in the death of a child. And the other main area of that was I was asked if we were going to bring my daughter, who was 3.5 at the time. And talking about young families who don't have experience with death, my first thought is I don't even think Isaiah's heard the word death before. Like I didn't even have it in my mind that we had said, oh, that flower is dead. I couldn't even picture that. And so it seemed so scary and so far away. And so I said, no, we're not bringing her. Same kind of thing. If there had been some expert guidance there of why I might want to bring Isaiah, why it might be okay, even though it is scary, the importance of her being able to say goodbye to her sister, which I know I made the right decision for myself at the time without that guidance, so I'm not harsh on myself about it. I wish I had made a different decision, and I think with a different type of support, I might have made a different decision. So just because a family is surrounding people, it looks like they have support, but they may not have all of the type of support that they need. And that's what I really have learned in reflecting back on our experience.
Thank you. Thank you to each and every one of you for speaking from hard-won experience, for preparing so much for the panel today, for opening your memories, your hearts, and your current experiences. And I believe we have time for questions from the audience. Do you want me to take the questions? Will you take them?
See if we can get the microphone. You can recognize people. Let me just say, Barbara, thank you so much for organizing this. It was very moving, very. We really appreciate all of your courage to share your stories with us. And if we can now, turn it over. And why don't you, Barbara, just go call them.
Okay. I see a hand right there.
I'd like to thank all of you for really very moving presentation. I think you left a lot of wet eyes in your audience, and thank you very much. I'd like to ask each of you to just tell us if there was one thing this panel could recommend that would have made a difference or will make a difference in what you're going through. What would that be from your perspective?
Could I ask you to give us your name and affiliation for the
Yeah,
webcast?
I'm Bernard Lowe from the Greenwald Foundation. I'm one of the committee members.
Okay, good. And everybody who asks the question, please identify yourself. Okay, I will open that here. One thing.
It's hard.
That's so difficult. I really think the take home for me is that whoever is caring for the patient, the caregiver, their partner, the family, whatever it is, that you listen to what they have to say. I think that because we live with them and we know all their little funky little idiosyncrasies, we notice the changes the most. I know that for me, Dusty's diagnosis of COPD, I know that it's a debilitating, it's going to be a degenerative thing. But when you notice an acute onset, that is not deterioration of the disease. That is an acute onset. And to be essentially I felt ignored, that nobody was listening to my observations, nor were we actually treating her acute onset. And that made a whole year of ugly for me, and several emergency room trips. So it's really, really important that you listen to their families. And I see that not only in myself, but I've seen this with friends. You know, as a nurse as a background, now mind you, I haven't worked in a hospital in years, I noticed that today nurses don't listen to family members. And it really compromises the care, and it compromises their life expectancy and their fulfilled life, so.
That, you know, that's a $1 million question. I think if I could boil it down, be human. And I say that with a very short example. When we did decide to go the Millerone route, it was 4 months later. And that was when I had to make that decision then. And in my mind, if we do this, we're quickening the pace. We've turned the corner. There's no going back now. The ER doc put his hand on my shoulder, and he recognized that I was wrestling with this, and he said, "Jim, you're doing the right thing." That's human. That's what you need to do. I don't care. Throw all the lawsuits out the window. That's what I needed at the time. You know, and this guy was willing to be human to help me go through this very human experience that not many other parents have the opportunity, or whatever you call it. That's probably not the best word, but you know what I'm saying.
I think the experience that that I can think of at this point is every now and then Murray and I make a trip to the emergency room, and we had to really argue with the emergency room doctor one time because I wanted to take him home. They wanted to observe him overnight, and I know how terribly uncomfortable he is, and he doesn't sleep, and it didn't seem to me that that was a healthful decision to have him spend the night in the hospital. So we, nobody steps on me very often, and so we got our way, took him home. He was just fine. This doctor even said, I said, well, if he has a problem, I'll bring him back. And the doctor said to me, well, this isn't a hotel where you can check in and out. So, I don't have a real high opinion of him, but he's the only one that has not, that I have that feeling about. But I'm sure he was thinking of his patient, and so was I. But anyway, we made the right decision that time anyway.
I first want to say that despite having the worst outcome possible, I feel that we did receive really wonderful care, and that Micah was cared for wonderfully during her time at the hospital. That said, I think maybe my take on would be that families maybe sense and know more than you think they know. So that day that I spent where her diagnosis changed, and it was very clear that they knew a lot earlier than they told us. And I know that has to do with coordinating, getting the right people in the room, getting this test, that. It's an impossible thing to synchronize perfectly, but there, I think, needs to be some kind of change in the way that we can be with families along the way versus no one talked to them until we know for sure. And it's very clear that no one's talking to you. So you are getting some information, even though you're not getting any information.
James Tulsky from Duke, a member of the committee. So, like the others have said, thank you to all of you for sharing such amazing stories. It's really helps, I think, make everything very vivid for all of us. I was struck by a number of things, but in particular, Jim, you said that at a certain point you really wanted the doctor to tell you what to do. And Ali, you talked about at the very end when you had to make the decision about when to turn off the ventilator, and that you felt like that was your decision and that was really hard. And I'm curious if the two of you, and perhaps the others if you want to, thinking about other situations, could talk a little bit about the tension between having the power to make your own decisions, and in many ways, medicine thinks a lot about making sure that people can make their own decisions, versus it's what I hear was some comfort and wanting direction of being told what to do. And for example, specifically, Ali, I'm curious if it had been presented to you differently, like, this is going to happen, and tomorrow sometime before noon, we're going to do this because she's no longer living. Would that have been easier for you, rather than sort of giving you this open-ended choice of when do you want to do this, and this is kind of a decision that somehow you have to make?
I think it's impossible, no matter how you look at it. I mean, I think it was maybe giving some, like you're saying, giving some parameters on it, like let's do this before X time would be good. But there's still, I think for me, no matter when it was, as a mother, having to say, like, now I'm ready. Like, you're never ready, but having to live with that, I made it, that at some point I said, now we're going to do it. At a certain point, that's just something that a family has to do. But maybe some help with some parameters around it versus leaving it all just totally wide open would help.
One thought on that I have is, we, like my wife and I, are very much processes, and we have charts, everything. So, and that's what kept our daughter alive, we believe, is part of why she was able to stay alive for 10 years. But I think a part of it is, give me the information, let me navigate through it, and ultimately I'm going to make the final decision as the parent. And I think, but don't give me too many options, because then I'm like, well, because the question I'm like is, what would you do if this was your child? That question will never be answered. But towards the end of Jillian's life, as we were talking with our doctor and we were transitioning to the hospice, we asked our doc, and my wife was very acute, and we said to him, you don't really know what to do with this one, do you? And he was very honest. He goes, yeah, this is not what we get trained to do. Yeah. And so having options is huge, giving us options. You could do A, B, C, or D, but if you give us 20, then we're like, oh, deer in the headlights. But if you give us a few and then maybe say, well, knowing your child, I might go with this one. I'm not one to want to get permission per se, but there's something about that when that doctor put his arm on my shoulder, said, it's okay, what you're doing is okay. It was more of an emotional permission than it was medical permission, I suppose. But I don't know if that helps at all or answers that.
Hi. Hi, I'm Judy Paris, a clinical social worker and a policy analyst with the Alterum Institute. I have like everybody, a appreciation of the heartfelt sharing that you all did, and thank you for that. I have a question that's sort of similar for Carla and Joanne, in the sense, Carla, that you were saying you did not expect this. And then Joanne, you were saying you wish you had known about palliative care earlier. I'm wondering if there's anything in your experience as you've been going through this journey that you can think of that would have helped to prepare you in some way, or to know about palliative care in a way that you maybe hadn't accessed before.
Go ahead.
Well, I think for me, I think when patients are given diagnoses that are obviously terminal, but who knows how long, I think that instead of having a bunch of specialists managing, that, because everybody's doing their own thing and they don't always talk to each other, and, because we all have our own worlds. But I think that in people who obviously are in a very limited capacity, and that they're going to have lots of debilitating occurrences, that perhaps referring to palliative care earlier, like with the initial diagnosis, would have been hugely different for us. I think that managing Dusty's symptoms would have greatly improved both of our lives. And, for me, I think it would have been way better to have a formal support system and know a little bit more about what I could do to make life easier. Life has been difficult. It's very stressful. I have a tendency to give in as far as, Dusty wants this, this, and this, because, we throw the dead card out. So, we have to get stuff done in a hurry. There is no waiting until tomorrow to do anything. It all has to be done right now. And I'm a procrastinator. I'm the first to admit it. I would do my study for finals the night before, read the entire book. So I have a tendency to put off, and Dusty makes it right in my face now. So now that, and I could have had support long before this, And I think that as a group, we need to move people towards palliative care much earlier because they're much better at looking at the whole patient and the whole family. And I think that is really, really important.
I think we went to palliative care just probably at the right time as far as Murray and I are concerned. But with my husband who died in 2001, we had a whole bunch of doctors, and I carried all his medications, so that every time we saw somebody, they could look over everything that everybody else was doing. So palliative care would have been a wonderful thing to have at that time. But as soon as someone suggested palliative care at VA hospital, we went right away without a question. So I feel very, very grateful for that opportunity.
One quick comment and one last question, and then we'll wrap it. You live in California. California is more progressive with regard to a number of factors, with regard to definition of extended family, with regard to leave from work, et cetera. Presumably that helped. Not all states have those things, and so to the extent that anybody wants to say anything about that, it would be helpful. But the last thing would be is, were there any things that were done or not done during your experience that you think that because of culture, policy, or payment systems, you wish it had been different, or you question whether or not it should have been different? And you may want to think about it. We're all going to take a break, so if you don't have an answer right now, we'll be around during the break. So, but while you're thinking, I do want to thank all of you for your moving and very insightful experience, and again for your courage to be here and share your stories with us.
I do have something that I would like to mention. Murray fell last October, and I happened to be out of the house. My son was there building the fence. But as I came home, there was the fire truck and the paramedics in front of the house. And first, since my son has all these saws and stuff out, I didn't know which one was the problem. And I found out that it was Murray, and he was sitting in the kitchen with blood dripping all over his face. He had fallen on his face, and he really was a mess. And at that time, the paramedics made the decision that he needed to go to a trauma center. And I said, we want to go to the VA hospital. Well, they wouldn't take us to the VA hospital. They wanted to take us to Valley Medical. Well, we didn't want to go there either, but they allowed us to go to Stanford Hospital, and which he had wonderful care. And he came home the next day, and he's, like the Energizer Bunny, he bounced back from that. But we're still dealing with the financial problems with that visit, and that's something that is really hurts him a lot, and it's very annoying to try to get it resolved.
Jim?
Well, there's something simple is probably what could be done better is, it goes without saying, the whole medical reimbursement. I can remember one day in the early diagnosis of my daughter, sitting in the living room with all the insurance paperwork out, strung all over the floor, trying to figure out how the heck am I going to pay all, or not so much that, but just trying to figure it out. Fortunately, because of her disability, moving to California, the insurance was sort of secondary covered by the Medicaid system. And so we never saw a lot of bills later on, but seeing those bills and seeing expenses, we could have been in a really tough position if we didn't have some other things done. So there's got to be a better way, especially with end-of-life care and families that, all the things that Lynn, was it? Yeah, it spoke earlier about creating a better system. It goes back to making that road as smooth as, there's gonna be potholes, let's fill those in. Let's fill those in and let's figure out a way to make it easier, so, yeah.
I just wanted to say one thing very quickly about policy and how important definitions are and how, even though California's progressive, I didn't mention both Avi and Micah, my daughter who died, were adopted from China. And my husband actually had taken the family temporary disability that California has. He had 6 weeks at 2/3 payment when we came home with Micah when she was adopted. So he had taken 4 weeks and was planning on using 2 weeks in the summer. I didn't mention she was 11 months old when she was adopted, and she was 1.5 years when she died. He tried to take those 2 weeks after she died and was told that he was not eligible for them because the person who he was taking them to bond with wasn't around anymore because she had died. So there's a little bit of, policies aren't perfect. Yeah.
Okay, on behalf of our committee and certainly Dave Walker, I think you've heard from all of us how appreciative we are for your thoughtful, compassionate, and caring comments. I think they're inspiring and they'll help us do our work in a very important way. Because we're an educational institution, VJ and Barbara are also recognized. As a former dean, I give out diplomas. So we have just a thank you certificate for each of you. You've taught us a lot, and we'd like to acknowledge that as well. We can applaud them as well.